that time of the season, and all through the house, everybody's doing something, playing ball outside, they're making music in the living room, a little mischief in the den. It's good to have everybody home again.
Oh, cool. Okay. So it's right side, so I could have done something like cool, but I'm not that technical. Both things going. You ready, sir? Is that? My name's Coleen Keller. I'm a faculty member here at the Health Science Center at the School of Nursing. I have a clinical practice primarily with children. I'm a family nurse practitioner at Ella Austin Clinic, which is an inner city clinic, and I also run a women's clinic for Planned Parenthood does take care of women, and I do an awful lot of midlife care and an awful lot of adolescent care. I recently published a book for SAGE called Health Promotion in the Elderly with a colleague from Chapel Hill. Came out in January of this year, and some of this talk is from that textbook. I gave you a reference list of all the research that underpins this talk that's in your notebook, and I also gave you tables from the textbook that we have on this that talk a little bit about dosages. We know after menopause the incidence of cardiovascular disease and the morbidity for women rises sharply to equal, if not exceed, that of men, primarily due to the lack of estrogen production. And for most practitioners, hormone replacement therapy is then recommended not only in the perimenopausal stage to alleviate the symptoms of menopause, but also for the prevention of osteoporosis, and it's well documented that estrogen supports that, and to reduce cardiovascular disease. And there's some evidence, beginning evidence, that it might help our thinking. And we know there's new data, primarily from the HERS study, that women are beginning to question a little bit whether it's really efficacious to take hormone, particularly estrogen, hormone replacement therapy in terms of secondary prevention. And the evidence is pretty clear that it's not necessary. But primary prevention, we still have some pretty good data that it's important. Nonetheless, the range of compliance with prescribed hormone replacement therapy is between 6 and 34%, less than 1/3 at the maximum, and less than 10% at the minimum of women taking this. A lot of women that I see are ethnically diverse at Planned Parenthood, and because they have multiple public health clinics, they're of low socioeconomic status. And many of these women, as you may know from your practice, have not seen a physician, particularly an OBGYN physician, for a female exam since the birth of their last child. Or I'll see a midwife woman who had never been prescribed or encouraged to take hormone replacement therapy. There is some data, though, that we know that even after a long hiatus between the absence of estrogen at menopause and starting to initiate it, there is some efficacious results, especially in bone rebuilding and possibly in elevating HDL and lowering total serum cholesterol. But we know that the compliance, again, is very dismal for taking hormone replacement therapy. Again, working at public health clinics, when I'm at the family practice clinic that I go to, write prescriptions all day long because practitioners have prescription privilege here. You walk outside after work and most of them are laying there by your car, because they throw them away because patients can't afford it. So we know that folks can't do it. So it's our job as healthcare providers to try to devise, if women are non-compliant or uninformed about hormone replacement therapy, to be at least knowledgeable about ourselves in order to prescribe or encourage women to use alternative sources to alleviate the sequelae of unfavorable lipids that occur after estrogen depletion, or to increase bone mass buildup. We're increasing our thinking. We all know lifestyle. That is, an adequate diet and exercise can give us virtually the same kind of positive effects in reversing unfavorable lipids, unless you have familial lipid problems, building up bone mass, helping us think clearly. But exercise and compliance with exercise and compliance with diet is as dismal, if not dismal, any lifestyle changes, than taking medication therapy. So what do we recommend to our patients? The biggest thing that we need to look at with our patients is antioxidant medications. When we have aerobic metabolism, we produce free radicals. And the majority of these free radicals that affect all the health of the cells are oxygen compounds. These molecules, if we have too many of these free radicals, they have toxic effects on the body tissue, and they cause biological damage to macromolecules such as DNA and our carbohydrates and proteins. This oxidation process has been associated with the pathological processes of various diseases such as diabetes, cancer, and coronary heart disease. Antioxidant defense systems exist, though, at the intracellular level. Their first function is to scavenge. That is, to decompose these free radical substances. There are three classes of antioxidants at the cellular level. These endogenously synthesized compounds, such as uric acid, exogenous derived antioxidants, such as vitamin E, ascorbic acid, and beta-carotene, and food-based non-nutrient antioxidants, such as the bioflavonoids and the polyphenols. Now, the flavonoids, I have this on here, are natural antioxidants that are found in many of the same food products as vitamin E. They're also naturally present in beverages such as tea, grape juice, and wine. There's a large amount of research that is emerging now to look at the beneficial effects of antioxidants and some synthetically derived compounds that are used as dietary complements. So what evidence, did I change it? There we go. What evidence do we have demonstrating that these antioxidant properties exist in these supplements? The tocopherols are lipophilic compounds, and they demonstrate their antioxidant properties in membrane tissue or in lipoprotein particles. They exert their action on lipid perioxyl radicals. They generate intermediate biochemical compounds that are less toxic to the PUFAs, the polyunsaturated fatty acids. Dietary sources of vitamin E may be found in vegetable oils, which is soybean, corn, cottonseed, virgin oil, and safflower oil, and products made from these oils, such as mayonnaise and margarine. Wheat germ is one of the best sources. Nuts and some green leafy vegetables are desirable sources. The minimum amount of vitamin E needed to protect PUFAs against oxidative damage is at least 0.4 to 0.8 milligram per gram of PUFAs, and maybe in excess of 1.5 milligram per gram if the individual diet is characterized by an excess of PUFAs. Vitamin E supplements provide independent protective effects against general and specific causes of mortality, and they can lower mortality rates by 27% and reduce heart disease mortality by 41% and decreasing cancer mortality by 22%. Most of these data, I will caution you, are not prospective clinical trials, randomized clinical trials, but retrospective data, primarily from the physician's health study and the nurse's health study. Two studies that I feel are just a little bit biased in the sense, and it started out with the original Framingham. How did we know the risk factors from heart disease? We took a bunch of people who were dead from heart disease and found all the risk factors that they had alike. It became prospective later. The nurses, we can assume, and physicians, we can assume, may lead healthier lifestyles than other population groups. So when we sit there and say, here are the folks that are living after 1978, when the nurses' health study started, these are the characteristics of their diet and their exercise pattern and the amount of vitamin intake and the specific vitamins that they took, we try to assume that the reduction in mortality of these women, at least from the nurses' health study, men and women nurses, is related to these. So there really is no cause and effect on these retrospective studies. However, you know, open up the newspaper on any given day and you've got some results, new results from the Nurses' Health Study. Fiber is one of the newest ones. Data does substantiate, though, that those individuals who have higher blood levels in dietary intakes of vitamin E have significantly lower CHD rates and decreased risk of heart attack, both in men and women. And in postmenopausal women, there's an inverse relationship between the intake of vitamin E from food sources and risk of death from CHD. Intakes of vitamin A and C did not appear to be associated, though, with this reduced risk. Two large prospective trials, like I said, the Physician's Health Study and the Nurses' Health Study, which composed of, you know, give or take, about 40,000 male health professionals and about 90,000 female nurses, found that the individuals who used vitamin E supplements daily for at least 2 years had 40% lower death rates from CHD and significantly less atherosclerosis compared to those who consumed much less of the vitamin. Short duration and doses less than 100 IUs had no effect. In patients with diagnosed CHD, doses of 400 to 800 IU of vitamin E daily over 1 year led to significantly lower risk of a subsequent non-fatal myocardial infarction. Platelet adherence to an injured blood vessel wall is thought to be the first step in the platelet-induced thrombus formation, and vitamin E affects platelet adhesion in a dose-dependent manner. So healthy volunteers in another study who ingested 200 units of vitamin E for 2 weeks showed a 44% reduction in platelet adherence, and 2 additional weeks of supplementation showed a decrease in platelet adherence of 77%. Vitamin E intakes much higher than the current recommendations have been shown to significantly reduce the oxidative alterations of LDLs. In one study, 1,000 IUs of vitamin E given for 7 days reduced oxidative resistance of LDLs by 41%. The vitamin also has a very wide safety margin made of sapphire. There's evidence that supplements of 200 to 2,000 IUs a day, which is 13 to 160 times the RDA for a period of 4.5 years, was safe. However, contraindications for the uses of therapeutic doses of vitamin E include GI upset, decreased iron absorption, decreased thyroid activity, and fatigue. Vitamin C. This is one of the most powerful natural antioxidants, and it also has pro-oxidant properties. It exerts its mechanism of action primarily as a scavenger, again, of free radicals and non-radical compounds such as hydrogen peroxide that act in a similar manner in biological systems. Vitamin C prevents the oxidation of LDL cholesterol and preserves vitamin E and beta-carotene levels during oxidative stress. The major food sources of vitamin C are fruits, especially citrus, kiwi, cherries, and melons, and vegetables such as the leafy green vegetables, tomatoes, broccoli, and cabbage. The minimum dosage found to be effective is 50 milligrams per day, obtained either through diet or through supplements. And while some data suggests that there may be an increase in urinary oxidate concentrations with high intakes, other studies show that there's a decrease in oxalate renal stones with high, that is greater than 1,500 milligrams doses. The effectiveness of ascorbic acid in the prevention of CHD is only hypothesized right now, and 3 mechanisms have been proposed. Ascorbic acid may retard the development of atherosclerosis by affecting the integrity of the arterial wall while aiding in the biosynthesis of collagen. It may alter the metabolism of cholesterol by mediating the conversion of cholesterol to bile acids. And finally, it may have an effect on triglyceride levels through modulation of lipoprotein lipase activity. There's been a number of in vitro studies that show another mode of action, that is the prevention of atherogenic oxidative modification of LDL cholesterol. Specific functions of vitamin C include the protection of polyunsaturated fatty acids, or PUFAs, against auto-oxidation and protein, protection against oxidative damage at the cellular level, by modulation of the immune response, and by decreasing the propensity of platelets to adhere to the vessel wall. Very similar protective functions that we've seen in vitamin E. Two major recent studies, the health profession study again and the nurses study, have not demonstrated any reduction in acute cardiac events related to vitamin C use. However, there are smaller studies that also do not demonstrate a reduction in deaths due to CHD mortality, but did indicate that stroke was reduced among the individuals in the highest third of vitamin intake. In addition to independent antioxidant activity, vitamin C can recycle the vitamin E radical. There's a need for an appropriate vitamin C-vitamin E ratio. Moderate to excessive vitamin E supplements of 70 to 1,000 milligrams substantially lowers plasma vitamin C in a dose-dependent manner. And it produces a direct decrease in the resistance of erythrocytes to hydrogen peroxide perioxidation. Vitamin E intakes greater than 70 milligrams in smokers and greater than 140 milligrams in non-smokers will promote oxidation if not accompanied by sufficient increases in vitamin C. We talk about the carotenoids. These are precursors to vitamin A. They're natural colorants with significant antioxidant activity. They scavenge perioxyl radicals by chemical reactions. Our food sources are carrots, tomatoes, citrus fruits, and spinach. High doses, that is greater than 30 milligrams a day, are very well tolerated, but are related to skin discoloration related to hyperkeratonemia. Supplemental doses of 25 milligrams each day have been recommended as safe for most adults. What evidence do we have that beta-carotene is efficacious? Again, Physicians' Health Study. The studies that we've looked at are Physicians' Health Study, the carotenoid and retinol efficacy trial, aka CAROT, and the alpha tocopherol beta-carotene study, the ABC study. These studies failed to find any benefit in beta-carotene supplementation and in some cases found significant increases in cancer. However, the significant increases in cancer were due to smokers who use this as a supplementation. So that's one of the stronger risks of taking this supplementation. In the Physicians' Health Study, the participants in the highest quintile of daily carotene intake, which was 19,000 international units a day, had a 4.8-fold reduction in relative risk for AMI compared to those in the lowest quintile. This observation was also demonstrated in the Lipid Research Clinic, the LRC study, follow-up study of men with type 2A hyperlipidemia. Patients in the highest quartile of serum carotenoid levels had a 36% reduction in risk. Now, some studies have examined combined antioxidant supplementation. The Women's Antioxidant Cardiovascular Study, WACS, and the Iowa Women's Health Study looked at these. In a randomized double-blind crossover design, placebo-controlled, participants who received the antioxidants alpha tocopherol, zinc, ascorbic acid, beta-carotene as dietary supplements experienced a significant reduction in systolic blood pressure. While some examinations of combined supplementation found no significant effects on cardiovascular risk, other intervention trials have found a dose-dependent effect on the inhibition of LDL oxidation. The WACS study is underway to determine the efficacy of antioxidant vitamin supplementation in CHD, stroke, and non-fatal myocardial infarction. In 41,000 postmenopausal women, the Iowa Women's Studies, Cushy and colleagues found that vitamin E intake from food was inversely related to the risk of death from CHD. This is food. And these findings held true even after adjustment of age and dietary intake. Vitamins A and C were not associated with a lower risk of CHD mortality, though. And nutrition supplementation study conducted among middle-aged adults in China evaluated the combination of 10 nutritional substances, including 125 milligrams of vitamin C and 30 milligrams of vitamin E. The combination of vitamin E with beta-carotene and selenium produced marginally significant reduction in mortality, primarily due to reduced mortalities from cancers. Protective benefits have been observed when dietary intakes of fruits and vegetables occur at only 1 to 2 times current recommendations intake, or the equivalent of 6 to 11 servings per day. The effect is theoretically presumed to be attributed to the complexity of the antioxidant defense system and the interactive effects of the combinations of nutrients and non-nutrient factors. Fish oil, blast from the past. Fish, the N3 fatty acids are important components of all cell membranes, and their metabolites have an anti-inflammatory effect. And it's hypothesized that the very long chain of N3 polyunsaturated fatty acids, again, N3 VLC puffus of fish oil, have a positive effect on lipid metabolism and on the hemostatic system. In a randomized placebo-controlled study of 47 healthy men, fish oil supplements were associated with a 30% decline in plasma triglycerides. The data aren't real strong, but at least it's present. Most prospective cohort studies report inverse associations between fish consumption and cardiovascular risk. In the Physicians' Health Study, 20,000 physicians followed for 11 years. The participants who consumed one fish meal a week, canned tuna fish, dark meat, or a shellfish, had a relative risk of sudden death of 0.48 compared to those who consumed less fish less than monthly. However, the information available concerning the efficacy of dietary fish oil has primarily been obtained from male subjects. So we don't know the efficacy for women. Calcium intake. We all know the decline in bone mass that occurs after estrogen depletion. In postmenopausal women, our fractional calcium absorption declines 21% per year. It's generally recommended that our calcium intake in elderly be between 1 gram and 1.3 to 1.5 gram per day to slow the decline of bone density. The efficiency of the absorption of calcium from supplements is greatest when calcium is taken in doses of 500 milligrams or less and consumed with meals that include dietary fat. The calcium content of food is, in fact, more important than its bioavailability, and certain foods have higher calcium bioavailability than others. For example, in comparison to available calcium from milk, available calcium content from dried beans is about half, with spinach about 1/10 that of milk. Folate and vitamin B6. Homocystinemia is an inborn error of metabolism characterized by vascular abnormalities and frequent arterial and venous thrombosis. This homocysteine damages cultured endothelial cells and stimulates growth of cultured smooth muscle by increased formation of cyclin messenger RNA. The thrombotic effects of homocysteine have been attributed to its effects on multiple coagulation factors, including platelets, tissue factor, activated protein C, lipoprotein A binding to fibrin, and factors 5, 7, and 9. Many individuals with cardiovascular, cerebrovascular, and peripheral vascular disease have elevated homocysteine levels. Moderate hyperhomocystinemia is a significant and independent risk factor for arteriosclerosis, comparable to the risk of cigarette smoking, hypertension, and hyperlipidemia. In the Framingham cohort, participants with deficiencies in folate, vitamin B6, and B12 had elevated levels of homocysteine, and these data were similar to that in the Nurses' Health Study, where the highest dietary intakes of folate and vitamin B6 had substantially reduced risk of CHD. There are 3 concerns about the safety of folate supplementation. Pernicious anemia can be masked, zinc function can be disrupted, and concurrent medications such as Dilantin can be antagonized. While some studies suggest that supplemental folic acid can affect zinc nutriture, others demonstrate there's no evidence of this. The current RDA of folate is 180 micrograms per deciliter, and for vitamin B6, 1.6 milligram per day. Food recommendations are those that are fortified with folic acid, and in our food supplies in this country, folate is supplemented to grain products to the tune of 140 micrograms per 100 grain of grain or 1 slice of bread. A woman who consumes 2 slices of fortified bread and 1/2 cup of fortified cereal will obtain an adequate intake of folate. Complementary therapies. a lot of my colleagues at the nursing school and in my women friends in the community have chosen consciously, as well-educated women, not to take hormone replacement therapy. Lots of women supplement with vitamins, but a large number of women are starting to look at complementary therapies in terms of reducing menopausal, perimenopausal, and menopausal symptoms. We see that the evidence here from some supplementation for increasing bone density, but there's other cardioprotective effects that we can see from our complementary therapy, which we're going to talk about a little bit. These phytoestrogens, they're naturally occurring sterols, and they're found in plants and their seeds. They're classified in three groups: isoflavones, which are plant sterol molecules. They're found in soy, garbanzo beans, and legumes. Ligands are a constituent of the cell wall of plants, and they're made bioavailable through intestinal activity after the consumption of grains and seed oils. Coumastands are found in such foods such as red clover, sunflower seeds, and bean sprouts, and these are an important source of estrogen for animals but not for humans. Recent research is focused on isoflavonoid phytoestrogens, the estrogenic plant chemicals found in soybeans and other legumes that act as potent estrogen among postmenopausal women. These dietary sources of estrogen have been associated with decreased risk of breast cancer, reduced serum cholesterol, increased HDL, and beneficial effects on bone mineral density. Several bioflavonoid compounds have been identified, but the main isoflavonoid are equol and its precursor diazen, and a metabolite of biocainin A called genistin. Trudy Bush, who's an endocrinologist on the West Coast, has been funded, I think this is her third year of funding, to examine the efficacy of genistin on cardiovascular outcomes and bone density outcomes in a randomized prospective clinical trial. So those results ought to be available soon. The isoflavones, genistin and diazen, are reported to be weak estrogens, and they've been found to have the same pharmacologic efficacy equivalent to the biologic hormone. Estrogenic flavonoids, such as genistin, demonstrate their mechanism of action through binding to estrogen receptor sites. They've been noted for their ability to function either as estrogens or anti-estrogens, depending on the biological environment and their chemical structures. In postmenopausal women who have low levels of endogenous estrogen, phytoestrogens may function as estrogens. Genistin in particular may act to inhibit cell growth and therefore the proliferation of hormone-dependent cancers by binding to the estrogen binding sites. Japanese women and women of Japanese descent Japanese descent in Hawaii who consume diets similar to the traditional Japanese diet, that is, phytoestrogen-rich soy products, have low breast cancer incidence and mortalities. There's limited evidence exists that phytoestrogens can have a beneficial effect on menopausal symptoms. In a real small study of 58 postmenopausal women, those whose diets were supplemented with soy flour had a significant decrease in the number of hot flushes experienced per week, and menopausal symptoms were also decreased significantly. In another short-term, that's 12-week, randomized clinical trial of 145 Israeli women who demonstrated an increase in SHBG, which is sex hormone binding globulin. These women who substituted phytoestrogen food sources for at least 1/4 of their diet increased their SHBG, and this was associated with the alleviation of hot flushes and urogenital symptoms. Again, phytoestrogens decrease platelet aggregation, just like our other supplements, and reduce serum cholesterol. In 805 older men, the inverse association was demonstrated between a high intake of flavonoids consumed in a daily diet, including specific fruits, vegetables, and beverages, and the incidence of myocardial infarction. Among peri and postmenopausal women who participated in a double-blind crossover clinical trial, those women who took 80 milligrams of isoflavones daily, which is 45 milligrams of genistin, demonstrated a 26% improvement in arterial wall elasticity compared to the placebo group. Several lines of evidence suggest that phytoestrogens also have a beneficial effect on bone mineral density. In vitro studies have shown a direct inhibitory effect of iproflavone on bone reabsorption and the growth and function of rat osteoblast-like cells. Short-term clinical trials using small samples of subjects have shown that iproflavone prevents the decline of bone density in older women as well as in bilaterally oophorectomized women. Phytoestrogens have also been isolated and identified in certain alcoholic beverages. Specifically, beta-sitosterol and biocatin A have been isolated from bourbon, and genistein and diadzin have been isolated from beer. Now, while we don't recommend alcohol consumption, because it's a non-nutrient beverage, the source does offer substantial benefit as an alternative to coffee or other caffeinated beverages, which are a risk factor for bone health. Green tea consumption, a staple of the Asian diet, has been found to be one of several protective factors against osteoporosis, and we're seeing that a resurgence of green tea purchases. They have a soy pill. I mean, this is not people. Not many people eat tofu and soy products. So they have, the General Nutrition Center and other places have marketed a soy pill. A couple of my colleagues tried that because of the distaste they have for tofu and other soy products. And unfortunately, one of them was 57 years old, started resuming her periods. So the dosage on the things that are commercially available may be a little bit less investigated than we'd like. So the recommendation is keep with food product from your soy consumption. That upside down. I want to go backwards on that. All right, you have a table for this. All these therapies, taking vitamin supplements, including calcium, vitamin A, vitamin C, vitamin E, have relative safety in terms of the ingestion. The soy products, we can't recommend an enormous intake of alcohol. The soy products have some kind of difficulty in the acceptance of women, particularly ethnic diverse women or women who haven't experienced a large variety of food dietary intakes. We do know that these are available in over-the-counter preparations, but it's kind of risky. You'll hear some other additional information about things like black cohosh, ginkgo biloba for increasing our thinking, black cohosh. Both of these substances obviously are not regulated, and we don't know the toxic effect of these on different internal organs. But some of these things, you can get soy products in flour, and if women are used to fried foods or baking, they can use soy flour in their baking. There are recipes on the web for smoothies, making soy product smoothies. Tofu, 100 milligrams of tofu contains 62 to 112 milligrams of isoflavones, and 120 grams of miso, if you've had miso soup, contain 40 milligrams of isoflavones. So not all of us who consume a traditional Asian diet can have this. We have to go out and have special adequate intakes of these. Adequate intakes of vitamins are recommended based on observational or experimentally determined approximations of the average nutrient intake by a defined population or group, and that seems to sustain a defined nutritional state. So the empirical evidence that we see in the use of vitamin supplements tells us that doses higher than the adequate intake or recommended daily requirements is really not warranted. For those individuals who choose to supplement, however, we should talk about the tolerable upper limits that one can take before internal organ damages for those fat-soluble vitamin internal organ damage might occur. The research concerning the safety and efficacy of these therapies is continuing, and findings from current clinical trials, such as the Women's Health Initiative, may render these and additional alternative therapies to hormone replacement therapy a little bit more precise in the near future. Thank you.
Have we any questions for Dr. Keller?
No clapping.
I remember, you have that 2-day gerontological nurse continuing education at UT.
She was the only one that showed up. Remember I said we had an audience one. The heavy girl? Was the heavy girl with me? Black hair? That's it. Well, you were the
Well, it's that time of the season, and all through the house everybody's doing